everyone. Thank you all for joining. Today we have the great honor and privilege of having Dr. Villamizar with us. Dr. Villamizar is an associate professor in the Division of Cardiothoracic Surgery at the University of Miami Miller School of Medicine and is a program director for the Cardiothoracic Surgery Residency. Dr. Villamizar did his residency in general surgery at Duke University Medical Center and completed his fellowship in cardiothoracic surgery at the Brigham and Women's Hospital. He has a particular interest in lung cancer sparing complex robotic segmentectomy for lung cancer. He is the medical director of the lung cancer screening program at the University of Miami. Dr. Villamizar, thank you so much for your time and willingness to be here with us.
Thank you very much for the invitation.
Thank you. So to introduce myself and my team, my name is Priyanka Senthil, and with me I have Anish Gugilam and Shuvek Venkateshwaran. We are part of the American Lung Cancer Screening Initiative, or ALCSI for short. And for those who might not be familiar with our organization, we have just a couple of slides to share about who we are. So ALCSI is a 501c3 nonprofit that works to raise awareness for lung cancer screening. We're a team of over 200 students and doctors located across the United States. And we do the work that we do because lung cancer is the deadliest cancer in the world, causing more deaths than breast, prostate, and colon cancers combined. Lung cancer causes about 380 deaths per day in the US alone. And lung cancer is very fatal because currently many patients are being diagnosed at a late stage when the cancer has grown and spread to other parts of the body. Lung cancer screening is an effective way to image the lung and can be used to screen for lung cancers early. But the only issue is that less than 6% of people at high risk for lung cancer are currently getting screened in the United States. And the screening rate for lung cancer is much lower than the screening rates for breast, cervical, and colon cancers, which are about 70%. And we believe that educating people about lung cancer screening is one of the most important and effective ways for us to increase the lung cancer screening rate for populations that would benefit from lung cancer screening. So far, we've given over 140 presentations on lung cancer screening to universities, hospitals, medical schools, and organizations around the US, as well as India, Canada, Brazil, and Mexico, reaching over 10,000 people. And over the last year, we worked with 140 mayors from every single US state to issue proclamations recognizing November as National Lung Cancer Awareness Month. We've also had the opportunity to work with several leaders at the state level, including Arizona State Senator Leela Alston, who is a lung cancer survivor, Pennsylvania Governor Tom Wolf, and Lieutenant Governor of Colorado, Diane Primavera, to increase awareness of lung cancer screening. And in addition to our education, outreach, and advocacy efforts, we recently started a podcast series to share the personal side of lung cancer and provide a platform for lung cancer survivors, advocates, and experts to share their stories and experiences around lung cancer. And ALCSI has also worked with US Congress members and senators to draft and advocate for the first ever House and Senate resolutions, recognizing the importance of the early detection of lung cancer through screening. And in December 2020, the Senate resolution was passed with unanimous consent, marking the first time the US Senate has ever recognized the importance of screening. ALCSI has also actively been working with Representative Brendan Boyle and Senator Tina Smith to draft and advocate for Catherine's Law for Lung Cancer Early Detection and Survival Act of 2021. Lastly, we want to end by talking a little bit about lung cancer screening. Lung cancer screening is done using a low-dose computed tomography scan. This scan uses low radiation doses, it's pain-free, and takes less than 5 minutes to complete. The United States Preventive Services Task Force, also known as the USPSTF, sets guidelines for who should be screened for lung cancer. And right now, they recommend that people between the ages of 50 and 80 who have a 20-pack-year smoking history or more, and who are current or former smokers who quit within the past 15 years, get annual low-dose CT scans. 1 pack year is defined as smoking on average 1 pack a day for 1 year, and therefore 20 pack years can be met in a multitude of ways, such as smoking 1 pack a day for 20 years or smoking 2 packs a day for 10 years, for example. So if you know anyone who might be eligible for lung cancer screening based on the criteria listed on the previous slide, please share the link given by this QR code so that they can contact one of our doctors about lung cancer screening. And finally, we want to highlight there are other risk factors for lung cancer in addition to smoking, such as exposure to asbestos, a family history of lung cancer, COPD, and previous radiation therapy to the lungs. We believe that it is important that we recognize these additional risk factors because a large number of people in the United States who have never smoked still get lung cancer. So thank you everyone for taking the time to listen to that quick presentation. And without further ado, we'll jump right into the podcast. We have a few questions prepared for Dr. Villamizar, but we'll transition to the audience Q&A at the end, where we will ask the questions that you all have submitted to us earlier. So first off, Dr. Villamizar, could you please introduce yourself and share your background?
Yeah, my name is Nestor Villamizar. I'm a thoracic surgeon here at the University of Miami. I'm originally from Colombia. I came here to the States to train in general surgery and in thoracic surgery. I have a special interest in robotic thoracic surgery, lung-sparing segmentectomy, and currently, I'm the medical director for the lung cancer screening program, and really that was a wonderful introduction. You cover many topics that are very important to educate the population about lung cancer screening.
In your eyes, what is the current status of both lung cancer as a whole, as well as lung cancer screening?
As you said in your introduction, lung cancer still is the leading killer cancer in the US for both men and women, and it kills more people than the other followers combined, prostate, breast, and colon cancer. The lung cancer screening, as you also mentioned, unfortunately, only 6% of the eligible patients are actually getting the low dose SCT for early detection.
Awesome, thank you so much. So how have things changed in the past 10 to 20 years with regards to lung cancer screening?
Yeah, not all is bad news. Part of the good news is that we have seen a decrease in the incidence of lung cancer over the past 10 to 20 years. And also we have better therapeutics. So that results in less people dying from lung cancer. And we also see an uptake in lung cancer screening. Many institutions have lung cancer screening programs. And your organization and others are really doing a very good job educating the population to get screened.
Doctor, could you tell us about some research projects that you're currently involved in, if you are, and just give us a little introduction and talk about what exactly you are doing?
Yeah. Well, my main interest at the moment is in clinical outcome research. So we started an initiative to basically lower the opioid consumption after thoracic surgery. So in our program, we developed the enhanced recovery after thoracic surgery protocol, aiming for 0 opioids at the time of discharge. So that's one of our main kind of like research projects. We also developed this virtual multidisciplinary clinic in the era of COVID, also trying to improve patient coordination of care, because lung cancer is a very complex disease, and depending on the stage, some patients are going to require multidisciplinary therapy that involves many healthcare providers, people from radiation oncology, medical oncology, and surgery. And frequently before, the era of telemedicine, then those patients will go to different clinics at different times. And sometimes it was hard to coordinate the care between providers, and that would result in delay so this gave us, this form of, Zoom associated with all the electronic medical records and all that, gave us the opportunity to, in a single encounter, have many physicians trying to help patients navigate through the process of, thoracic oncology, thoracic cancers. So those are like my main projects. We also have some projects related to lung cancer screening. Here in Miami, we have a very large Hispanic population. If you see the number of Hispanic patients that was included in the NLST trial, then it was equivalent just to like 1.8%. So we were interested in actually knowing, if the same kind of findings that they had in the NLST would apply to our population here in Miami, and kind of like find out what are the obstacles for patients to get screened. And we basically, in this population, found out that there is a non-compliance of about 30% for all comers, meaning that if you have a negative chest CT scan, the possibility of the patient coming the next year was only about like 30%. So we're trying to improve that, making patient aware that this is not like a one-time visit kind of deal, but this really should be an annual low-dose chest CT as long as they have a negative chest CT scan. And it didn't appear that just by itself, being a Hispanic versus a non-white Hispanic was associated with a dramatic difference in terms of compliance. Both populations had about the same percentage of compliance, around 30%.
So you mentioned that only about 30% of patients receive a negative CT scan come back the next year to get another CT scan. So in your opinion, what do you think are some of the strategies that we can use to increase this compliance rate above 30%?
Yeah, I think it's difficult sometimes to engage patients on screening programs. I think that we need to do a better job. We know that patients that are engaged in a lung cancer screening program have a better chance of quitting smoking. That's that gives us the opportunity to actually help patients to quit smoking. But then we need to make them aware that the risk is a long-term risk, and that's why the criteria is within 15 years of quitting smoking. So just try to emphasize that breaking many of those myths about lung cancer, about the radiation exposure. All these things that are going to probably are preventing patients from coming back. Make them aware that the best chance that they have to get cured from lung cancer is when we detect them early, and the strategies with the low dose annual chest CT scan really help to do that.
So I know you just mentioned radiation exposure, and that's actually a concern for a lot of patients. One of the major concerns is radiation exposure, but then also false positives. And so can you please discuss both radiation exposure and false positives, and why they shouldn't be a major concern for patients when thinking about CT screening?
Yes, so we know that from previous studies, the rate of a positive scan, which is reported as a long RAS 3 to 4X, is about 16%. So then we're dealing with that rate of positive CT scans. And out of those, only about 2 to 3% are going to result in lung cancer, meaning that we have about a 13% of false positive rate. Now, that doesn't mean that that would result in an unnecessary intervention. Programs in institutions that have invested in guidelines of how to manage patients with a positive CT scan have demonstrated that the rate of an unnecessary intervention is about 3 in 1,000, so 0.3%, okay? And then we also know that the low dose radiation CT scan is really a low dose. And there are studies that say that for the risk of inducing cancer related to the radiation that you get from a low dose CT would be something like, you would get one patient with cancer-induced radiation for 208 patients that you're gonna save by doing a CT scan and detecting lung cancer at an earlier stage. So in the risk-benefit ratio, so that's what we need to explain to patients, then it is a much higher risk for them not to have the CT scan and the early detection for lung cancer than to have any cancer associated with the radiation exposure that they're getting.
So one question that we often get is that it's very common to have lung cancer nodules. And so if a patient has lung cancer nodules on a CT scan, what are usually the next steps? Does it require follow-up testing or follow-up imaging? Or what factors are taken into consideration when determining whether lung cancer nodules are benign or might be suspicious for being metastatic or malignant?
Yeah, there are several factors that we take into account. One of the things is that we differentiate whether this is what we call the baseline CT scan, meaning the first CT scan that the patient has for lung cancer screening, or if this is a follow-up CT scan and a year later, okay? So whenever we have a new lung nodule, the first thing that we try to figure out is if the patient had a previous CT scan, because for us it's very important to compare the two CT scans and the interval of time that has passed between the two, and then see if there has been growth. That is one of the main determinants of a lung nodule being suspicious for lung cancer, if there has been an interval growth, okay? So then if it is in the baseline CT scan, unless it is a big mass that is very concerning, if it is a small nodule, smaller than 1.5 centimeters, then we typically do another CT scan in 3 months, and then we have the two CT scans to compare that growth rate. Because we know that the majority of lung nodules that we find in people are going to be benign. So we kind of need to first prove that there is that high suspicion of malignancy before we jump into doing any sort of biopsy or surgery or anything like that. So the least invasive way to do that is to just get another imaging study. Now, when these nodules are larger than 1.5 centimeters, and that's when we start, being a little more concerned about this being possibly lung cancer, then we do a different imaging study, which is called the PET. And the PET is the one that kind of like captures the activity of the cells. And then if we have what we call a hypermetabolic, a nodule that is active, okay? Then that raises the concern for potentially being lung cancer. Of course, we have to take into account whether the patient had a history of cancer anywhere else, because some cancers go and do metastasize to the lungs, or if this is a patient that lives in a place where there is a lot of infections and things like that, fungi and things like that, that could also create lung nodules. And then only when all these things, like the nodule is growing, it is active on the PET and that kind of thing, that's when we start contemplating to do interventions such as biopsy or an operation.
In your years of experience with dealing with patients and just noticing some common trends, what are some misconceptions you would say that patients have about lung cancer and lung cancer screening?
Yeah, as you mentioned also in the introduction, many people think that the only way that you can get lung cancer is if you smoke or if you have smoked in the past, and that's not true. What is truth is that smoking is the highest risk factor to have lung cancer. However, there are other important risk factors such as the family history. You know, if your parents or your siblings had a history of lung cancer, you're at a higher risk. And sometimes in some populations, that even plays a more important role than smoking. And many other the factors that you mentioned in your introduction. So that's one of the myths that the people have. The other one is that because we have, portrayed lung cancer as a deadly cancer, which it is, then people assume that when the cancer is detected, then there is nothing they can do to be cured. And we know that the lung cancer is a big family of different cancers with different kind of aggressiveness. So some of them are more aggressive than others, the ones that we can detect early, then many of them we can cure. That's another one of those misconceptions. And then in terms of lung cancer screening, we already mentioned the misconception of basically having a lot of false positive scans with unnecessary interventions, and the misconception of having a high dose radiation that could result in cancers anywhere, somewhere else.
Great. So you mentioned that one of the risk factors for lung cancer is a family history of lung cancer. And so in the current 2021 USPSTF lung cancer screening guidelines, these other risk factors such as a family history of lung cancer or exposure to secondhand smoke, exposure to radon and asbestos, these other known risk factors for lung cancer are not being accounted for. And so what are your personal recommendations for individuals who are at high risk for lung cancer for any of these other risk factors, but are not eligible for lung cancer screening according to the current lung cancer screening guidelines?
So interestingly, some lung cancer screening programs, including ours, offer a low dose chest CT scan to people who are interested in having these scans outside the guidelines that are being covered by Medicare and the insurance companies. It needs to be carefully share decision-making process. I would not recommend that just because you have those risk factors, you go ahead on your own and get a CT scan, because results can be confusing and you can be on a pathway of these false positive resulting in unnecessary interventions, not only in terms of lung nodules, but in anything else that is involved in the chest, in the heart. Then they are going to mention that the coronary arteries have calcium, and it's going to create a lot of anxiety in people to have all these reports, with many things that probably did not need to be acted upon Now, if you go to a center that has the expertise in lung cancer screening program, there is always that shared decision making with a healthcare provider. And in those situations, when you balance the risk and the benefits, I think that those high risk individuals would benefit from having a low dose CT.
We briefly touched upon this earlier, and this is one of the core subjects of lung cancer, which is the stigma surrounding it, where people automatically assume that it can be a smoker's disease. But what do you believe is the role of doctors as a whole, whether that's oncologists, radiologists, thoracic surgeons, in addressing the stigma around lung cancer and help educating the public about how lung cancer actually is a disease?
Yeah, I think that, with programs like yours, trying to make people aware of other risk factors for lung cancer and all that hopefully is going to reduce this stigma of a smoker's cancer kind of thing. And the other thing is that, what we should also emphasize is that this is an opportunity for us to help patients quit smoking, because it's not only lung cancer that is associated with smoking. There are many other cancers and other diseases that really are associated with smoking. And we know that, the smoking is an addiction as many other substances, that cause addiction. And then we just need to basically help them to fight it. So, give them the tools to be able to overcome the addiction. And then also just to make them aware that if we detect the lung cancer in an earlier stage, they can be cured, and that needs to be like the emphasis of that conversation. Not to make them feel guilty about being dependent on smoking, but just trying to help them quit and also engage with lung cancer screening programs.
Yeah, I think that's a really important topic, because we've had some lung cancer patients on our podcast previously, and a really common theme, an unfortunate theme that we've seen is that for sometimes the first questions that patients receive is, I didn't know that you were a smoker, or something along those lines. And it doesn't really matter whether they were a smoker or weren't a smoker. Lung cancer can affect anyone, and no one deserves it. And so that having that be the first question that they receive after sharing their diagnosis with someone, I think that's very that's very detrimental. So educating people about the stigma about lung cancer and how we can work as a community to overcome it, I think that's very, very important going forward. And so you mentioned the importance of also helping patients quit smoking. And so in your opinion, are there any particular smoking cessation programs or resources that you would recommend for anyone listening?
In our program, we have kind of like a smoking cessation program consultation with a specialist, but I know that there are many kind of like phone lines that are advertised on the radio and things like that. So, people quit smoking in different ways. There are patients that just decide cold turkey to quit smoking and they do well, but others that really cannot do that and then require, help from PCPs and things like that to provide some additional therapies that can help them quit smoking. So I know there are many resources that patients can find. I don't know of any specific one that I would recommend.
The data usually shows that the lung cancer screening rate is often lower in patients of Black, Hispanic, and Native American race. So how can we best reach these priority populations and increase the lung cancer screening rate specifically in those populations?
Yeah, I think that this is common not only for lung cancer screening, but to basically a problem with access to healthcare. So I think that that's what we need to recognize, that really there are disparities in healthcare and that needs to be addressed from the public health perspective and from like individual communities trying to emphasize the importance of that and trying to reach out to them, similar to what happened during COVID, in vaccination rates and things like that. Sometimes it's not only enough just to basically welcome patients into your health care system to get these therapies, but actually to reach out, do more like outreach, to go to their communities to kind of make it easier for them to access care.
So what do you believe is the biggest challenge for the lung cancer field?
I think that, having only a 6% rate of eligible patients to undergo lung cancer screening that are actually getting screened it's a really bad statistics. I believe that for screening in breast and colon and all that, I've seen numbers close to 50% or something like that. So we are way far from those screening programs. So that's, at the moment, I would consider it as like the biggest challenge, because that would be, I would say, probably the most effective way to reduce the death rate from lung cancer. It is always good to know that there are advances in chemotherapy, immunotherapy for late stage disease, but if we focus on the early detection, I think that we would have a higher impact in reducing the mortality of this deadly cancer.
What advice do you have for an individual who may be eligible for lung cancer screening but has not yet undergone the screening?
Definitely to participate in this shared decision-making process and understand the benefits of the early detection of lung cancer, and just to contact the lung cancer screening program that is being offered in his community or her community.
So in the beginning of the podcast, we talked about how the lung cancer field has changed in the past 10 to 20 years. So to kind of go full circle, what do you believe is in stock for the future of lung cancer screening?
I'm optimistic. I see as you very well give the example, I see more people, young people, interested in educating patients and making them aware of these the benefits of early lung cancer detection through these lung cancer screening programs. I see more and more institutions that have a lung cancer screening program, and in fact, to be a member of the National Cancer or under the umbrella of the National Cancer Institute, then your institution, your cancer center must have a lung cancer screening program. So all these initiatives, I think that really are going to make a big impact in trying to get more people screened.
Thank you so much, Dr. Villamizar, for taking time out of your day to share your work with us. Now I'd like to transition into the Q&A section. We have a couple questions from the audience, and if you're comfortable and share as much as you could, that'd be awesome.
Absolutely. Thank you for the invitation.
Awesome. So I'll start off the Q&A with the question we received. The person asked, I've been hearing about targeted therapies for lung cancer. Could you please talk more about them?
Yes, so I guess the three big families of systemic therapies for lung cancer. That means a therapy that it is not related to just the nodule that you can see on the CT scan, but more if there are any cells in the body that are traveling that maybe started with that nodule in the lung, but now are traveling in the bloodstream that you want to basically kill, then the three big families of these systemic therapies are: one, chemotherapy, that many people are familiar with, the one that is toxic and sometimes is associated with hair loss and nausea and all this other stuff. Then there is the family of immunotherapy, which is basically giving a boost to the immune system so your own body is fighting against cancer, okay? And then there is these other big families of target therapies, because some cancers have specific mutations, and then there is a drug that is specific for that mutation, and that's why it's called targeted therapy. So in lung cancer, we have, for example, the EGFR mutation. There are good, drugs that are very effective in killing those cancer cells when the cells have the EGFR mutation. So it's targeted to that specific receptor in those cells, so they get killed.
Thank you. This question is a little bit of a broader question. The person asked, could you talk about the difference between non-small cell lung cancer and small cell lung cancer, particularly focusing on how the treatment options might differ for small cell lung cancer and non-small cell lung cancer?
Yes, so the two big families of lung cancer are those: the small cell lung cancer, which accounts for about 15% of all lung cancers. And the other big family is the non-small cell lung cancer, which is the more common one, which accounts for about 85%. And that family of non-small cell lung cancer divides in many other families or smaller families, which are the adenocarcinoma, squamous cell carcinoma, carcinoid tumors, and others that are less frequent. Now, in terms of the therapeutics, is different. The small cell lung cancer, when it's found, typically is found in a later stage of disease when the cells are already traveling in the bloodstream. So the main therapy for small cell lung cancer is this systemic therapy, as I mentioned in the previous question. And so then it's chemotherapy and immunotherapy now is proven to be effective against small cell lung cancer. And some patients, when they have very limited disease, sometimes in these cases are like incidentally found nodules, for example, in a lung cancer screening program, then if they are what we call localized to the lung as a stage 1, then they actually could benefit from surgery, even if it is a small cell lung cancer, followed by the systemic therapy because of the high rate of the cancer coming back or cells already traveling in the bloodstream. The ones that are what we call locally advanced, not only they are inside the lung tissue itself, but also on the lymph nodes that are nearby, those are usually treated with chemotherapy and radiation combined. And those are not eligible for an operation because the operation really does not add any benefit when it's compared with the treatment with chemotherapy and radiation combined. That is for the small cell lung cancer. Now, in the bigger family, which this is the non-small cell lung cancer, the main therapy that is associated with cure is surgery. But not everyone is eligible for surgery. It depends on the stage. And then the stage we determine is depending on the size of the tumor. That's one characteristic. And if the tumor has already traveled to the lymph nodes, and if the lymph nodes are the ones that are inside the lung or the ones that are in the middle of the chest, that is called the mediastinum, or if the tumor has already traveled elsewhere, some in other place in the body. So that's how we determine kind of like the sequence in which we are going to treat the patients. Some of them, we like to give the systemic therapy first and then do an operation. Other cases, we operate first and then we give the systemic therapy. And when they are already like, let's say in many places in the body, like the bone, the brain, and other places, then usually surgery is not of benefit. So then they go into systemic therapy only. It depends on the stage.
In your eyes, what are some of the factors that patients should consider when deciding whether or not to participate in certain clinical trials?
So, you know, the kind of like the armamentarium of therapies against lung cancer has dramatically increased in the last few years. So I think that is very important for patients to go to centers of expertise that have clinical trials, because as a patient, you rarely know what the stage of your disease is. So then you're gonna start with a series of you know, imaging studies and procedures and things like that. So if you knew up front that you are going to be just like a stage 1, then perhaps the clinical trial would not be of benefit. But if you're gonna end up being a stage 3 or a stage 4, then those are patients that would definitely benefit at least from having that conversation of what's available.
Thank you. And the last question that we have from the audience is, what are some promising projects in research in the lung cancer field that you've heard of and that excite you?
So, you know, recently in the international meetings, we have presented the outcomes after giving patients chemotherapy plus immunotherapy and then surgery. And we have seen a dramatic improvement in the response of the cancers and in the survival. That, you know, what we anticipate to be increasing survival in cancer with advanced stages. We are operating on people that we never thought that we would operate in the past. Many of them very young patients that already had stage 4 lung cancer, that had metastases in other places in the body, that started with treatments with systemic therapy, you know, chemotherapy and immunotherapy, and then they respond so well that all it's left is the cancer in the lung, that we're now willing to operate and give them, you know, probability of cure, or at least of, you know, long-term survival. So, you know, we're very excited about it. Now, the other really interesting, you know, study that was presented is this idea that patients can have a smaller operation with similar outcomes. You know, for the last, you know, several decades, we thought that the main operation for lung cancer, even if it was very small, was to remove the entire lobe, a lobectomy. And now we know that the outcomes, the long-term survival is even better when we do a smaller operation, trying to spare more lung. Presumably because patients, you know, that have lung cancer, that get cured from lung cancer have a higher risk in the long term to develop as what we call a second primary, meaning another lung cancer. So that's another population that is not in the guidelines of lung cancer screening, but that we certainly follow every year, is the people that already had lung cancer, had an operation, and now we are doing this surveillance every year to make sure that if they develop another cancer, we caught it early. So when we do an operation that is smaller, then we leave more lung for the patient. If they develop another cancer, we still can continue to operate or give radiation, or with the idea of like curing them, even if the lung cancer comes back 20 years later, a different one, a new lung cancer.
On that note, I think we can conclude today's podcast. Thank you so much, Dr. Villamizar, for your willingness to share your story and perspective on many of the pressing issues in the lung cancer world. We truly appreciate all the work and research you are doing. And thank you to everyone.
Thank you very much for the invitation.
No, sorry. Thank you. Thank you, everyone, for listening and joining our podcast. Please keep an eye out for our upcoming podcasts and events, which will be listed on our website, www.alci.org. Thank you and have a great day.
Thank you.
Thank you, Dr. Villamizar.
Thank
Thanks,
you.
everyone.